sound check right now. Okay, great. Thank you, everyone. I have some good feedback there. Great. And I will try to speak as well as I can into. We have several people in the room with us today, so we're using kind of a conference call system. So also the webinar will be recorded, and we will notify you. We'll be posting that on our healthoregon.gov/coronavirus webpage for people to view after today. So introductions. Joining us today on the phone remotely is Dr. David Blairfield. He's an EMS physician with an interest in regionalized systems of care. He brings data to drive clinical practice. He started his career in medicine as EMT in 1990 and continued on to gain his credentials as a paramedic and later as a physician in both the military and civilian worlds. He currently serves as the Oregon State EMS and Trauma Medical Director and works in the emergency department at the Portland Veterans Affairs Medical Center. We also have Dr. Richard Lehman. Dr. Lehman is the Chief Medical Officer for the Health Security Preparedness and Response Team, medical epidemiologist and tribal epidemiology liaison in acute communicable diseases prevention public health division of the Oregon Health Authority. He's been in the public health division since 2002. Before that, he completed an epidemiologic intelligence service fellowship in applied epidemiology with the CDC and worked with the Indian Health Service National Epidemiology Program throughout the 2 years of his fellowship. He's board certified in family practice and worked as a family physician for a number of years with the Monoma County Health Department and the Celebs Community Health Clinic. So thank you, Dr. Swoll, for joining us today to answer questions.
Glad to be here. Thanks.
And for all of you that don't know me, how to host a normal webinar, my name is Rebecca Long, paramedic and mobile training unit coordinator here at the Oregon Health Authority, EMS and Trauma Systems. Thank you again for joining us. So to start us off, I just again want to thank everybody for attending today, and thank you everyone for sending in questions. We did go through those yesterday, as many as we could. We're answering quite a few of them today. We're going to direct you to places to get more answers if you have more questions. If we have time at the end of the presentation, we will open it up for people to ask questions during the presentation. So again, if we don't get to your question, we have them all recorded, and we're going to try and get them all answered as best we can. We'll all have a handout in the sidebar control bar of the webinar. In the handout, there is a document with several links. We're going to be referring to a lot of those links today. So please save that to your desktop, save it on your computer so you can access it later. It's got links to one of the first things here is our new healthoregon.gov/coronavirus website. Everything that we have latest up to date is going to be on this website. So please mark that, put it as a favorite on your internet tab and save it, because this is where all of the information is going to be coming out, and it is changed and updated regularly. For anyone that can't see the phone call, we've had a question just momentarily. The phone number to dial in is 1-562-247-8321, and the access code is 263-776-858#. So we're going to go through some guidance that we have again on the handout. So initial guidance is going to be for the public safety answering points, or your PSAPs, through your dispatch centers. We're asking the dispatch centers to follow the guidance again that's on the handout to screen all callers for the following: fever, cough, difficulty breathing, any travel outside the continental U.S. within 14 days of symptom onset, as the patient had close contact within 6 feet with a person confirmed. Dispatch centers use the Medical Priority Dispatch Systems, MPDS, or equivalent dispatch card 6 for breathing problems, or 26 for sick person. If a patient meets this criteria, please provide medical care per protocol. Alert responding agencies of the possibility of an infectious patient as soon as possible prior to arrival. Follow local public health authority policies for reporting and follow-up with healthcare workers who contact to suspected cases. And again, that's going to be a link in the handout. If patients do not meet the criteria, please continue the questioning and follow appropriate case entry instructions. Stand by, everybody. Hang on. Thank you. If a healthcare provider suspects a patient may have novel coronavirus, and these are going to be, so the first couple slides are for dispatch centers, these next couple slides are for EMS personnel and first responders. The healthcare personnel should use droplet and airborne precautions. Please mute yourself if you've called in. Thank you. Please use disposable patient examination gloves and change them if they become contaminated. Please use a disposable isolation gown and respiratory protection N95 or higher level respirator.
Okay.
Again, please, if you've just called into the webinar, please mute your phone.
Can we do a mute from here on this one?
No, because we've got two things.
Thank you. So respiratory protection, yes.
Let everybody know, definitely don't put us on hold. Because
last thing too, please don't put us on hold on your phone.
Love hold music, but not during webinars. So.
Yeah, it does get transmitted for everyone. Thank you. Eye protection as well. Please use goggles or a disposable face shield that fully covers in the front or the sides of your face. Your normal everyday reading glasses or glasses are not sufficient, so please wear goggles or a disposable face shield over that. I'm going to direct everyone to one of the handouts. The handout that's dated March 3rd of 2020 has some great information on PPE. Again, this is the latest stuff that came out yesterday. One thing that we do want to direct everyone to right here, it's highlighted on the second page, everything that should be worn. And it also elaborates into extensive contact. So if you're, especially in a healthcare setting at the hospital and you're in a room with these patients, there's extra precautions that should be taken. We want to also really focus on have people wear eye protection, because what we've found from other agencies is that the failure to use eye protection in addition to the mask has been a key factor in other worker exclusions to date. So again, please make sure you guys have your eye protection on. Okay, so when you guys come into contact with a patient, please ensure that the patient is masked. Once the screening questions are complete, you can limit healthcare staff to minimize possible exposure. So sending in one provider, as long as the patient isn't acute, is completely fine. The EMS history screening questions that should follow. Does the patient have a fever or symptoms of lower respiratory infection, such as a cough or shortness of breath? And have they traveled outside of the continental United States within 14 days of symptom onset, or have they had close contact within 6 feet with a person confirmed with COVID-19 infection? If your patient meets the previous criteria, keep the patient masked unless medical intervention is necessary. Use caution with aerosol generating procedures and ventilate your ambulance if possible. Please note that aerosol generating procedures are anything that will stimulate your patient to cough, suctioning of the airways, intubation, etc. If the patient meets the previous criteria, please notify the receiving hospital of a potential infection control as soon as possible. Disinfect. You're using EPA-registered disinfectants with known effectiveness against the human coronavirus. Please note these are most of our wipes that we're already using. We do have a list too that we're going to put up from the CDC. The novel coronavirus is not a hardy virus, so most of the stuff that we carry should cover this, but please make sure it's stated on the back of the container. And follow public health authority policies for reporting and follow up of healthcare workers with contact to suspected cases. There's also a link to all of the public health contacts in the handout. So we'll move into some of the questions. Forgive me, guys. I know you guys are typing in questions. I will filter through those here as soon as we can. One of them kind of get through this speech, but I do see you guys sending in questions. Thank you for those. One of the first questions we have is, what are the current recommendations for PPE for healthcare providers? So again, we got this question a lot, as to be expected. You're going to see this link a lot. Again, it's in your handout. Please go to our website and look up the Oregon Interim Infection Control Guidance. Again, some of the stuff that we showed on the screen previously, and what we've already just talked about, we're listed on there. So there's specific guidance depending on the level of care you're providing for those patients. Please go to our website and you can print out all of these documents, handout.
Yeah, and it is remarkable. This is Richard Lehman. It is remarkable, but even though, David was slaving away and got this guidance together for EMS personnel on the 29th, things continue to change, and so you will see a few differences between what we have in here and what is in the guidance that was just released yesterday. So if you've got somebody with febrile respiratory illness and you do not have evidence that this person has a direct link to a known COVID-19 case, we don't know that they were just in China or Korea, and we haven't had a chance to do any testing to rule out other things because flu is still circulating. It's still in the area. So if you get somebody with febrile respiratory illness, based on what we know about transmission of this virus and what's likely to be out there in the community, it's okay to go with eye protection and a surgical mask. You don't necessarily need to have the N95. If you're really thinking that it's COVID-19 because of a definite risk factor, known contact with somebody who's a known case, then CDC would recommend going with airborne precautions. We recognize that's not always easy, but for many people with febrile respiratory illness, it would be okay to use eye protection and a surgical mask. Thanks, Rebecca.
No, that's perfect. Thank you, Dr. Raymond. Another question we received. N95 masks are out of stock. How should healthcare providers respond to potential COVID-19 patients?
Do you want me to tackle that one, or do you?
Well, initially, people can reach out again on their handout. There's a link to your public health. The public health providers can go on and request through their county health department resources. Again, that's one of the things we want everybody to do. If you need something, please run it through the appropriate channels, and it will get to the appropriate people. But you can request supplies.
Yeah, this is Richard Lehman. I would say before that, though, we want to wring everything that we can out of your usual procurement systems. So if you need to push them hard for what you need. And I don't know how often this happens with EMS, but we've seen some health systems, hospitals that have agreements where they can only get product from a given company with whom they have a contract. And I think back on that, if a company, you have an agreement like that and the company is not holding up their end of the bargain, then it makes sense to say, look, I need to look elsewhere unless you can supply me with what I need. So we really want to do things through existing systems. We do have some respirators, N95 respirators, in a cache, but it's not huge. The state does not have a huge cache of this, and we want to use it judiciously.
Thank you very much, Dr. Lehman. Okay, another question. What are the best cleaning practices for equipment and units? Again, on the website and in the handout, the infection control guidance, disinfect using the EPA registered disinfectants and let them air dry as we would with other viruses we've seen. Another question we received, what recommendations do you have regarding all allied health programs in the area who have students on clinical rotation? Please have the students take the same precautions as paid staff at facilities. If individual facilities have the capacity to provide proper PPE to the students on rotation, they can continue with their work. If facilities do not have this capacity, the rotation can be postponed.
Okay.
I think we missed.
I think we can. Yeah.
Oh, did I skip a question?
14.
Oh, thank you. Sorry, buddy. Another question. Do we anticipate a point where the screening questions would be asked on all 911 medical calls, regardless of signs and symptoms? Again, please check back to the website for regular updates. Everything that's related to COVID-19 that we're learning, we will push out to everyone on our healthoregon.gov/coronavirus.
Yeah, and this is Richard Lehman. Short answer to that is no. We don't anticipate that. If somebody's got a broken leg or a sprained ankle, you're not going to need to ask that. And we don't think that this is very well transmitted based on what we've seen so far by an asymptomatic person. It's possible there's a mild risk of transmission. There may be some asymptomatic shedding, but we really think that the big problem is when somebody is actively ill, coughing, broadcasting goo and droplets all over the place.
Thank you, Dr. Lehman. Another question, would it be appropriate to limit the size of crew treating or transporting a patient with suspected COVID-19? Yes, that's completely appropriate to limit the number of staff, again, as long as the patient is stable. Anything to add to that, Dr. Lehman?
That sounds reasonable to me.
Is self-transport an appropriate option for stable patients with the means to transport themselves? Again, yes, limiting crew exposure is ideal as long as the patient is stable. Please follow your local protocols once you've made contact with that patient for refusal procedures. Are dispatch centers screening callers preventing EMS providers from unnecessary exposure? Again, like I talked about in the beginning of the webinar, there are guidance out for the PSAPs. Hopefully they are following those. Please contact your local PSAP and work with them to make sure that they're following these guidelines and that they have received the same notification that you have.
Yeah, that's going to be big. Folks who are going out and responding to a call should have that information as early as possible so that they can take appropriate steps to protect themselves. And that's also obviously important for the community, that you folks are able to do what you need to do and do it safely.
Sorry, I'm getting a lot of questions about the website. So healthcareoregon.gov.
Oh, no, Health Oregon.
Health Oregon, thank you, Dana. healthoregon.gov/coronavirus. If you search this, our website will come up as the first link. So
yeah. Also, if you just Google Oregon Public Health Division, there's a banner, and you click on that banner for novel coronavirus, and that'll get you there.
And again, it is on your handout. There is a hyperlink in your handout. Thank you. Another question, is the most appropriate question still, have you traveled to China within the past number of days? Again, the questioning should follow the interim guidance. Has the patient traveled outside the continental U.S. within 14 days of symptom onset, or have they had close contact within 6 feet with a person confirmed with COVID-19?
Yeah, and we do think that travel to areas where there is wide community spread, active community spread, is a risk factor. But let's face it, we've got this here, we've got this in Seattle. So this, we may fall off on doing this. I don't know about, we may transition away from this, but for now, that's still a meaningful risk factor.
Great, thank you. So, Dr. Lehman, what are the most helpful interventions when treating a patient with suspected COVID-19?
Serves me right for looking at my phone. So, well, I think basically, nothing is set in stone about this. It's kind of driven by how this person is presenting. We don't have a specific treatment for this that is well documented. There are some experimental antivirals that are being looked into, but I think the key thing is evaluating your person. Care is supportive, and basically it's going to be driven by the clinical presentation. If the person is hypoxic or dyspneic, then probably getting some O2 on them is a good idea. If they look like they're hypovolemic, then maybe giving some fluids on board. Transport time.
There's a non-transport time.
Mm-hmm.
So depending on what your transport time is, this is Dana Sullivan, the state EMS and common director, by the way, and Liz Heckathorn, the deputy state EMS and common director, is also in the room. So considering what your transport is, treating those symptoms makes the most sense.
Thank you. Next question, Dr. Lehman. COVID-19 is in our community. What history questions should be asked to determine a patient's possible exposure risk, especially if the chief complaint is different?
Well, I think you do want to pin down what the symptoms are. So you want to find out if there is fever, cough, or shortness of breath. I think it's still worth finding out if this person was in a region where there's widespread transmission. And you want to find out if you know that there are any cases in your area. It makes sense to find out if this person had any known close face-to-face contact with somebody who's known to have COVID-19. And this, this may become somewhat more common as we move forward with this, but I think that's important to know because those are potentially people at higher risk. If they were in direct contact within 6 feet, or they got coughed on by somebody who was sick with this, that's a high-risk person.
Thank you. What is the criteria for self-isolation or quarantine related to fire and EMS responders? And when should these providers be taken out of service? I think we touched on that earlier, and we have lots of handouts to direct them to the new questioning and the table.
Yeah, and Richard Lehman again. I think basically if an EMS responder has close, prolonged contact with a patient who has COVID-19 and was not taking the recommended infection precautions, certainly at least droplet precautions, then that may be a situation where we need to think about self-quarantine at this point anyway. We're certainly recognizing that we don't want to do that lightly. We know that you folks do important work out there, and we don't want to take out an entire ambulance service unit. And so that's all the more reason to make sure that if you're seeing somebody with a febrile respiratory illness, that you go ahead and put on a mask and put on eye protection before you engage with that person. That's a good way to prevent yourself from having to get furloughed.
And again, everybody, I'm just showing you in the handout dated March 3rd, there's great tables in here to ask yourself those questions too, of what exact exposure that your providers might have had. Okay.
Rebecca, I think it's also important to remember as we're looking at exposures to think about exposures with the appropriate PPE and without, because any exposure is not necessarily an immediate furlough or work exclusion. It's really, that's why using the appropriate PPE with the eyes, mouth, and nose really is really important.
Yeah,
remember,
it's big.
There have been lots of work exclusion recommendations because of the lack of eye protection, and so that's really important to pay attention to. So there's exposure, but it's not isolated. It's exposure with the appropriate PPE, and healthcare providers should be trained to don and doff and to work with that like any infectious. This is a new infectious disease, but the concepts are really similar to those which you already hopefully are trained in, and making sure that everyone is trained and ready to respond in a protected way so that they don't have to be excluded from work.
Right, and it also just decreases your risk of getting infected, right? Whether it's COVID-19 or anything else. You don't want to get flu either. You don't want to get human metapneumovirus. You don't want to get other things that are circulating that make you feel rotten and that kind of take you out of action probably. And you don't want to infect your families. So taking the right steps with PPE and infection prevention is important.
Okay, next question. Is there an estimated number of people who have had or have COVID-19 but have never reported this to their primary care provider for confirmation?
So we don't really have great data on this for Oregon or for any place else. I mean, I think we're still learning about this. We don't think that there are that many cases from what we've been seeing in Oregon right now, and we do think that some people with COVID-19 have relatively mild infection. It seems to be worse if people have underlying heart or lung disease, diabetes. There's a question about whether even high blood pressure might put people at higher risk. I don't really know, but people who have underlying chronic conditions are at higher risk. So I think the key message is if people don't need to be seen, maybe they're a bit sick with fever, maybe they have a cough. Just because you have fever and a cough does not mean you have to go into the emergency room, does not mean you necessarily have to be seen. If somebody's sick enough that they need to be seen, that's when they should be. But they don't have to just go in at the drop of a hat as soon as they start coughing.
Thank you. Make sure I'm on the right slide for everybody.
I'm looking at 24, I think.
24.
Besides using universal precautions, is there anything else first responders can do to prevent contracting the virus?
Sure, and not just when you're responding. Not just when you're in the ambulance going out to evaluate somebody. Certainly, we're hoping that our friends in public safety answering points can find out for you if this patient that you're going to be evaluating has febrile respiratory illness, and that way you can take appropriate steps to protect yourself, and that's going to be important. We do think you should be using at least droplet precautions and eye protection in that situation, because sometimes you get nailed in the eye. That's the reason for the eye protection. We're not just making it up. And the other thing is just basic social distancing. I mean, even if you're not on the job, if you can be staying a little further away from people, and certainly if somebody's coughing, if you don't go right up in front of them and get coughed on, that's a step in the right direction. The other things, you know, we hear this all the time, but we say them over and over again because they work. Cleaning your hands, washing your hands. If you can't wash your hands with soap and warm water frequently, you can use an alcohol-based hand sanitizer with 65% alcohol or more, and that kills this virus. So using those things, and certainly if there's somebody at work who's sick, they should stay home until they're better. They should not bring it in. And if you're sick, you should not bring it in.
Thank you. Next question, is the virus transmitted via droplets or is it airborne? Second part to that, are they streamlining the testing process for those who are presumptive positive?
So we've kind of beaten this one into the ground already. CDC is recommending and being very cautious and saying maybe this could be airborne spread. From what we know of other coronaviruses, including SARS, which is the coronavirus that is most closely related to this one, it's droplet precautions. So we probably will, I'm hopeful that we will get to a point where we have enough evidence that people are going to say, yep, it's droplet precautions. But for right now, if you know you've got a case or somebody who's very high risk, the recommendation is to go with airborne precautions. Still, we think it's probably droplet spread. Are we streamlining testing process? So I'm guessing what this means is, can we get confirmation from CDC more quickly on somebody who's a presumptive positive tested at the state public health lab? And once our public health labs in states get enough results that are consistent with CDC's, the need for that confirmatory testing is probably going to go away. But for now, that's what we need to do.
Thank you.
But we are trying to do that as expeditiously as possible. It does, of course, involve flying something 3,000 miles, so it takes a little time.
Again, kind of a same thing. What are the transmission mechanisms? I think we've talked about that at length. But how long does the virus survive on surfaces? Do we know?
We don't know for sure. This is an envelope virus. It appears to be a fairly wimpy virus, but has anybody been able to say, this is how long it survives on the surface? No. I think we should assume that it potentially can stay there for, at least a couple of days. And the key message is, let's do something to clean places where it might be. And so if you're transporting somebody and somebody's been coughing all over your rig, first, before that happens, get a mask on that person so that that's containing. You want to contain that if somebody's coughing. Everybody who has febrile respiratory illness should be getting a mask put on them early. If indeed they're frequently touched surfaces, whether this be at home or at work, cleaning those with just your usual disinfectants is adequate to kill this stuff. So that's our goal. Then you don't have to worry about how long it can last.
Right, and this is Dana Silver. We'll refer you back to the guidance in the documents that are posted on our website. There's some good sort of not that, it's any different than your normal your terminal cleaning after you've had a patient, but those specific guidelines and reminders are in the guidance that we provided, and that is available on the CDC's website also.
Yeah.
So.
Perfect, thank you. Do we know the rate that COVID-19 is spreading across the U.S.?
So in certain places, like unfortunately up in Washington, somehow somebody who was ill appears to have gotten into a long-term care facility where there were a bunch of people who had other healthcare conditions, and it did not end well. So there have been individual situations like that. In general, we're still learning. What we've learned from China is that, at least as far as severe illness, it appears that for every one person who's infected, it appears we might expect 2 additional cases. So, you know, that's enough spread that you can potentially have broader spread, but it's not, say, measles, where 1 case in an unprotected population results in 12 to 18 additional cases. So nowhere near as contagious as measles, about the same as influenza is what it's looking like at this point. So, you know, our goal is to try to slow spread. That's why we need to do those things we talked about as far as staying a little farther away from people, cleaning surfaces, making sure if you're sick that you stay home, washing your hands regularly. These are the tools that we have that we used during H1N1, and they worked. And we can do this again. We just have to be prepared to take it seriously.
Thank you, Dr. Lehman. How would you differentiate COVID-19 from the common cold or flu?
I don't know that we can in all cases. Colds usually don't have much of a fever. I think flu and COVID-19 would tend to present pretty similarly. Maybe myalgia, muscle aches are more common in flu than they are in COVID-19. But I think what we do is we just take precautions that we think are going to help protect us either way. You don't want to get any of these things. So using eye protection and a surgical mask at a minimum, if you've got somebody with febrile respiratory illness, I think is a good step.
Thank you. Is the person who has been infected by COVID-19 immune from future infections? I might have skipped a portion of that.
Did we miss one?
We did. Actually, let's go back to that one first. Sorry. What is the current thinking surrounding COVID-19 being seasonal, worse in winter, like the common influenza strains?
Well, I guess we'll know in a month or two. I don't think we know that, so we'll see. And we'll be doing some surveillance for influenza-like illness. We have a network of clinicians and clinics around the state that help us with that, and we're going to continue to work with them in order to see whether it slows down. We certainly saw that happen with H1N1. It first appeared in April, then it kind of went away for quite a while, but I'm not promising anything. We'll find out.
Thank you. Is a person who has been infected by COVID-19 immune from future infections?
We don't know that for sure. This is an RNA virus, so it may be a little less stable than a DNA virus, where the nucleic acid in there is DNA, which is double-stranded and which doesn't get broken as easily as single-stranded RNA. With influenza, we do see kind of gradual drift, and that's the reason you have to get a new flu shot every year, because there may have been a little drift in terms of how the virus looks to your immune system. We don't know if that's going to happen with this. We think probably in the short term, if you got infected and generated antibodies to it, and it's the same strain that's circulating, you probably are protected. Just common sense from an immunology point of view, but we don't have a definite answer for that for long-term immunity.
Okay, thank you. Dr. Lairfield also wanted to add that people can use alcohol sanitizer on their gloves before doffing them, before taking them off, as another step in the decon process. So now we're going to move on to some of the live questions that you guys are typing into our chat box. Thank you for that. Dr. Lehman, I'm not sure if you want to just start kind of from the top down, or...
Oh, I can't read them, so...
So,
do you want me to?
Yeah, you
do you want to pick them?
I'm too sure we can do that.
And we'll tell you, no, not that one. No.
Sure.
And you haven't covered already.
Yeah.
Right. One of the questions earlier, and forgive me, the questions come in as the presentation started, so some of them might come back to the beginning. When we're talking about aerosolized interventions or treatments, would that include albuterol treatments on that?
You know, we had many discussions about that back during H1N1. I think it is not considered to be as high risk as, say, suctioning or intubating. I don't think it's a bad idea to protect yourself in that situation, but from what I remember from the what was determined back a few years ago, it's not quite as high risk, but maybe not zero.
Okay, thank you. With information out of Seattle that has possibly been around for several weeks, why are we not asking people about travel to the area with known patients? Most will have no idea they were within 6 feet.
Yeah, and if you're within 6 feet, but it was just like that, you walked by, that's not an exposure unless you got nailed by somebody who was coughing. We're talking more like close face-to-face contact within 6 feet for probably an hour while this person was actively symptomatic, between the time they became ill and when they entered isolation. So, yeah, it's possible that people could get exposed to somebody and it was not known that that person had COVID-19, but that's why we're taking all of these steps, or we hope people will be taking all of these steps in order to protect themselves by doing social distancing and by washing their hands, and by people who are sick, whether they have this or something else, covering their coughs and staying home when they're sick. So, yeah, we may be adding additional places to the list of concerns, but I think we should just assume that this is circulating in the community. It may be circulating at a low level. It may be that it's never going to get to be a much higher level, but hope is not a strategy, as my nephew likes to say. So we just should assume that it's potentially around and take the appropriate steps to protect ourselves.
Thank you. Any word on pregnant women who may be exposed? Is the child in utero protected, or if the mom gets it, does the baby get COVID-19 as well? Do we know?
Don't have a lot of information on that. We might be able to glean something from what China has found, although I have not seen something specific on that. I think potentially, because that person's system is working for two, metabolism is higher. I don't know. I mean, it's a good idea, certainly, for a pregnant woman not to get any febrile respiratory illness. And so those are people who should be taking good care of themselves. I think as far as from an EMS point of view, if the person is doing fine, is doing well, they may have a bit of a fever, that does not necessarily require transport, but they do need to be given parameters, call parameters, in case they are getting worse. They need to know that they need to think about getting evaluated.
Thank you. Because of the unavailability of N95 masks, what is the opinion of potentially reusing a mask more than once?
I don't think we're there. I think the first thing, and David and I had talked about this on the phone before, you need to work your systems hard, your procurement systems hard. That's the first step. Don't take no for an answer. Don't take, I mean, we need to make sure that we are using that as much as possible. If you have done everything, there's actually guidance, I believe, on our website about some strategies to go through to make sure that you can get stuff out of your procurement system. If that is just not working for you, then we'd want you to call local public health, and we can see if we can figure things out. But I don't think we're at the point where we need to be reusing masks. One thing we've noticed is that a lot of N95s are getting used for fit testing. And that's not necessarily, but I mean, one thing to consider is just-in-time fit testing. I guess that would not work quite as well in the EMS setting, but maybe it makes sense if you're talking about reusing masks. Maybe that's, for healthy people who are doing their fit testing. Or maybe if you've got some expired masks, you use those for fit testing. David, I don't know if you have any thoughts on that, if you can chime in, but those are my thoughts. We're not there.
Yeah, Richard, this is David. I agree with you. We're not there. The CDC has some really good guidance on this if you want to go to their website, but using expired or reusing PPE for fit testing is one way to conserve. There's some really good guidance about limiting healthcare worker that are exposed to infectious patients, and only those identified cohorts of healthcare workers would contact those patients is another way to limit your use. I also think there's, if you're a small agency that has, as Richard mentioned, a single source provider for your PPE, you can look to mutual aid through your regional organizations and through your county for PPE. And again, big healthcare systems have greater pull with suppliers. So I would partner with healthcare systems, look to mutual aid, review the CDC's guidance on conserving your PPE. They have a very nice document that we can send out the link to with some really good administrative and logistic strategies to conserve PPE. If push comes to shove, and I agree with Richard, I don't think we're there, and you need help from the county or state level, then you would follow your usual channels through your local public health department and county OEM to push your ESF8 requests up to us.
Thank you, David.
Dr. Lehman, we've had several questions revolving around ventilators and BiPAP and CPAP. So one question was, if people are on a ventilator, does the HEPA filter in there protect the provider taking care of that patient? I guess would be the first question. And if we don't know, we don't know.
Yeah, not something that I have looked into specifically. I think if you've got a HEPA filter in there, that's probably helpful. But don't know the specific answer to that. Sorry.
Thank you. Another question was around CPAP and BiPAP. Should those be avoided as those aerosolized interventions, or is that also another form of kind of helping put a mask on the patient? Would you recommend for or against?
So I think it kind of depends on the clinical presentation of the person, if that's what's needed for somebody. And do you guys do that do you do that out in the field?
Yes, we do.
Wow, isn't that something? So again, I think it depends on what the person needs. And if that's what the person needs, then I think that's what you do, and you take appropriate steps to protect yourself, which we hope you're doing anyway. In terms of infection prevention strategies.
Thank you. Another question was, should law enforcement adjust their response for cardiac arrest due to the lack of protective equipment? And this is Elizabeth Ekaforen, manager for the EMS and Trauma program.
Hi, everybody. So at this time, the answer is no. Sorry, but they should not adjust their response to cardiac arrest.
Actually, we're not even apologizing for that.
Right, and this is Dana Silver. So we are working with a lot of different agencies, specifically fire and other public safety agencies, fire and police, to give guidance around what sorts of protection that those other agencies that are not primary healthcare providers always, but they certainly are very involved in some or adjacent to healthcare provision, in this case police are, so that they are preparing themselves to be protected with the basic PPE, which they should be doing already because flu is out there and someone can have the flu and a cardiac arrest at the same time, and we would not respond to that person because they have the flu. So I would treat it like any other droplet infection.
Thank you.
May I,
No,
this is David, may I say a word on the past few topics?
Yes, go ahead, David.
Well, I was just, you know, these questions about cardiac arrest and limiting procedures are sort of dancing around the topic of alternate standards of care. And I think we need to have a little perspective on this. So there's still lots of people out there with upper respiratory infections, most of which are not going to be COVID infections. From what we know, it appears that the COVID has about the same infection rate as the flu. I think there were like 241 positive flu cases in Oregon last week, and there was been 3 of COVID. So when you're considering perhaps not following your normal standards of care, whether that be albuterol or BiPAP or doing CPR on a dead person, you have to ask yourself, you know, what is your index of suspicion that this is not one of the more common diseases out there, and that is this actual rare disease, and that you can't protect yourself from this disease, and so you're going to have to move to alternate systems of care. That's a discussion that should be thought of ahead of time. And again, I just want to emphasize, and I think Richard would agree here, I don't think we're anywhere close to alternate standards of care in our system yet.
Yeah, I think if you're familiar with the Oregon Crisis Care Guidance, we're still in green. We're still in the conventional mode. We've had our shot across the bow that this is going on. It's a good time to make sure that your oxygen tanks are full. It's a good time to work with your procurement systems to make sure that you've got what you need to keep doing your work. But yeah, we're not into a situation where we are like massively overburdened, I hope, at this point. And we will be looking at that at the state and working with partners in healthcare, and including EMS, as things unfold. I guess the other point I would make is, as far as what we do in terms of interventions for people, this does not appear to be as dangerous, you know, as bad an infection as, say, meningococcus. And meningococcus is droplet spread, and we take care of people with that. we do what we need to do to take care of them, and if we do it in a way that we're using appropriate personal protective equipment, droplet precautions, we can, you don't stop taking care of people just because they have a bad disease. You do what you need to do to protect yourself, so that you can do what you need to do.
Yeah, and this is Dana Silver, and I hope that Dr. Lehman and Norfeld will chime in on this. But there have been a couple of questions that are around the topic of exposure and being exposed or being adjacent to, and kind of working through that exposure, both with your employer and local public health. And the exposures are explained in detail in some of the materials that Rebecca directed you to, specifically that March 3rd revised document, which I want you to kind of take a look at and go through and be completely clear with both your employer and your local public health. If you have a certain amount of exposure, are you a person under monitoring? And that is something that you need to work out locally. So I'm not going to be able to give you all of the process and the procedure today, but I would refer you to that document and refer you to sending in specific questions both to your local public health provider who is responsible for doing that monitoring. That's not a state activity mainly. We are a level up from that. And work with your provider. There are also a couple of questions about OHA and fit testing and monitoring. So I would say, I'm going to turn over to Dr. Lima as far as if you feel like you are one of those exposed individuals, what to do.
So we're working with OHA and just actually had a call with them the day before yesterday, and we'll continue to work with them because obviously they're an important partner in this as well. But yeah, I'm not sure exactly what the question was around exposure, but it does appear that this is not just casual contact walking by somebody. This is like either getting coughed on or being in close prolonged contact without having without infection prevention.
The notification process.
Do we have any information about, crews are asking about if they transport a patient and then it turns out that they do come back positive, how's the notification process coming down from the hospitals or clinics back to those providers?
I think it's through local public health.
And actually, yeah, that would be through public health if we have somebody who ends up being a case or somebody who is strongly suspected, a so-called person under investigation, then public health has been reaching out to close contacts, figuring out who those close contacts are. And so probably there would be a preliminary reach out to the responding ambulance service to try to figure out who actually might be considered somebody exposed.
Thank you. Couple more questions. If you have a patient who's suspected of COVID-19, can we put them on a lower level mask or should they have an N95 as well?
Oh, that's just a regular surgical mask for them. There's no benefit to an N95, and basically the idea is just you're putting something in front of their mouth so that if they cough, you're capturing those heavy droplets, which is the way we think that this is primarily transmitted.
Do we know right now, Dr. Lehman, how long the confirmatory tests are taking from the CDC?
Somebody does, but I do not.
Fair enough.
Right, and we did talk about if it does become community-wide, please be watching for changes in testing requirements. That may come in the future. Just right now, we have our protocols right now, but those things change. So that is one thing that I do want to leave everyone with is that there may be some frequently asked questions coming out that we're going to be able to post, but those are almost on a daily basis are overhauled, which is why we have not done FAQs specifically for EMS beyond our guidance, because we would be updating them ongoing, and we want to make sure that we're posting things, that you are accessing resources that are as up to date as possible. And if you have to go through 2 and 3 things through our FAQs and then check again, that doesn't make as much sense. But I'll definitely Dr. Lehman.
But I was just going to say, as far as the question about time for confirmation, I think just staying in touch. If this is not a general question, but a specific question about one of the 3 cases in Oregon that we're aware of, I think just talking to the local health department, because they would be able to stay up on when confirmation has been received. And I think people have had a low threshold for putting out press releases related to this stuff, so that might happen as well. If it's just a broader question about how long does it take to confirm, my hope is that in the not too distant future, we will have had enough samples confirmed by CDC that we won't have to go through that step.
Great, thank you. One last thing, it's 12:02. The doctors are very, very busy. They need to get back into other meetings. One last thing, I apologize for the confusion on the website, everybody. It's healthoregon.org, healthoregon.org/coronavirus. So again, please look at the handouts that I gave you, and you can find our website pretty easily now. Thank you, everyone, for joining the webinar today. Thank you, Dr. Lehman, Dr. Lehrfeld, Elizabeth Hexhorn, and Dr. Dana Sullivan. I appreciate everybody's time today. Thank you, everyone. Have a good afternoon.
Oh, yeah.